faculty members and participants who have joined from various parts of India and abroad. Welcome to this webinar. I am Sumit Kumar Madan from Zydus Life Sciences. On behalf of Zydus, I welcome our guest speaker, Dr. Manju Sengar, Chief Guest, Dr. Tanuja Sheth, all discussants and participants to this virtual symposium on PTCL diagnosis and management. Before we commence the proceedings, I would like to welcome and introduce the convener for this webinar under the Aegis of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit is a passionate and dynamic hematologist and bone marrow transplant physician from Surat in Gujarat. I request Dr. Amit Khurana to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit. Let me share the screen. Well, very good morning to all of you, and good afternoon and good evening from other people from the rest of the world. Today, our guest speaker for the day is Dr. Manju Sengar from Mumbai. She is going to lecture us on peripheral T-cell lymphoma, diagnosis and management. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, dedicated to life, and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and Team Zydus, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Tanuja Sheth from Mumbai, our guest speaker, Dr. Manju Sengar from Mumbai, all our discussants who are themselves eminent hematologists or medical oncologists, and you participants for sparing your Sunday morning, afternoon and evening. Next Saturday, that is on 4th March, we have a webinar on CAR T-cell therapy in AML by Dr. Vipul Sheth from Washington, USA. And the following day, that is at 11:30 a.m. on Sunday, 5th March, we have an excellent webinar on MPN for young people and pregnancy by Dr. Claire Harrison from London, UK. Now it's a time to introduce all our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Akansha Garg from AIIMS Jodhpur, Dr. Anand Gokan from Tata Memorial Hospital Center, Mumbai, Dr. Anupama Jagya from NHS Trust London, Dr. Ashish Bakshi from Bethany Hospital, Karuna Hospital, Borivali, Dr. Deepak Charles from Aster Medicity, Kochi, Dr. Gaurav Prakash from PGI Chandigarh, Dr. Gopinathan M from SGPJ Lucknow, Dr. Gunjan Prasad from Apollo Clinicals Hospital, Kolkata, Dr. Radhika KK from Nizam's Institute of Medical Sciences, Hyderabad, Dr. Kunal Goyal from Tata Memorial Hospital, Varanasi, Dr. Lingraj Nayak from Tata Memorial Hospital, Mumbai, Dr. Mullidharan C from CTC PHO BMC Center, Borivali, Mumbai, Dr. Parthiv Mehta from Jivanti Hospital, Bhavnagar, Dr. Prashanta Bhatt from KMC Hospital, Mangaluru, Dr. Reena Nair from Tata Medical Center, Kolkata, Dr. Roshni Pandey from Mahakoshal Hospital, Jabalpur, Dr. Satish Kumar A from Manipal Hospital, Yashwantpur, Bengaluru, Dr. Shailendra Prasad Verma from King's George Medical University, Lucknow, Dr. Siddharth Sankar Ray from Institute of Hematology and Transfusion Medicine, Medical College, Kolkata, Dr. Stalin Bala Chaudhary from Nizam's Institute of Medical Sciences, Hyderabad, Dr. Sundar Shivale from Tata Medical Center, Kolkata, Dr. Thomas Kuncheria from All India Institute of Medical Sciences, Bhubaneswar. Now it's a time to introduce our special guest for the day, Dr. Tanuja Sheth from Mumbai. Dr. Tanuja Sheth is professor at Department of Pathology, Tata Memorial Hospital, Parel, Mumbai, and it's my privilege to invite her to inaugurate our webinar and give some words of wisdom. Over to you, Professor Dr. Tanuja Sheth.
Good morning. Hi, good morning all. At the outset, I would like to thank Dr. Agrawal for starting these MAG's meetings. They are so interesting. And as a pathologist, as much as possible, I try to attend it. So, I think in medicine, what's most important that our learning never stops. At any age, you can't say that you know a disease very well. And if there is a disease that if after 20 years of doing lymphomas, I still don't understand, that's a peripheral T-cell lymphoma. And as you can ask people in Tata Hospital Department of Pathology, I'm sitting in my room, I'm surrounded by these slides that are 10, 15 years old. I keep picking them up every now and then, and I'm still lost in that world. And when I'm lost in that world, I get a call on the phone about a patient. And if that clinician is Dr. Manju Senkar, I'm happy, because I think we need clinicians also to understand the complexity of lymphomas. And I think these talks, never sit in your room in isolation. As a pathologist, we have to connect with patients and our medical oncologist. As a medical oncologist, you have to connect to your pathologist, however crazy he or she might be, and understand the world of lymphomas. And I think peripheral T-cell lymphomas are very interesting. They're interesting because they beat every textbook picture. You decide that this is how AITL looks, and next day you will see an image that looks totally. Soon the WHO will keep revising their classifications, their entities, because how much ever long we go, the more complexities are revealed. And as I said, the cells don't listen to us, and our learning has to keep on occurring. And I'm very glad that I'm here on this Sunday morning to listen to Dr. Manju Senkar, because I think in Tata we are comfortable. I think the pathologist, medical oncologist equation decides how any lymphoma for that matter, but especially a peripheral T-cell lymphoma, because these days we know that in T-cell lymphomas, you can't say that they're aggressive and they die like, in a 6 months, because you have now got a lot of indolent forms. And 10 years back, if I say this looks like an indolent T-cell lymphoma, people would say that I'm mad, and they still say that I'm mad. But today we know that there are so many different cells of origins of T-cell lymphomas. I think this, if you try to read a T-cell lymphoma, you will be the most interested person in the field of oncology. So thank you, Dr. Agrawal, Dr. Amit, for this opportunity. And over to you, Manju, for your words of wisdom.
Thank you so much, ma'am, for that words of wisdom. It means a lot to us. Now is the time to introduce our guest speaker for the day, Dr. Manju Senkar from Mumbai. Dr. Manju Senkar doesn't require any introduction, but it's my duty to introduce her. Dr. Manju Senkar is MD Medicine, DM Medical Oncology, is Professor, Adult Hematolymphoid Disease Management Group, Medical Oncology at Tata Memorial Hospital, Mumbai. She completed her training in medical oncology from All India Institute of Medical Sciences, New Delhi. She has done a postgraduate diploma in clinical trials from London School of Hygiene and Tropical Medicine external program. She is an Accord alumnus. She is a recipient of American Society of Hematology Visitor Training Program Fellowship at Duke University, Durham. Her main areas of clinical research are non-Hodgkin's lymphoma, adult acute lymphoblastic leukemia, and supportive care. She is a principal investigator for several investigator-initiated studies and has participated in industry-sponsored multi-center clinical trials. She is going to lecture us today on peripheral T-cell lymphoma, diagnosis and management. Over to you, ma'am, for your lecture. Thank you so much.
Thank you so much, Amit, for that kind introduction, and Dr. Tanuja for, making the background of what we are going to do today is not easy for any one of us. And thank you, Dr. Agrawal, for having me here. It's always a pleasure to participate in these meetings. What I'm going to talk today is diagnosis and management. I've tried to keep this talk more towards addressing the, what a postgraduate student or somebody who's an early career hematologist or medical oncologist would want to know with respect to peripheral T-cell lymphoma. I do have a bad throat from my last week's journey to Varanasi, and it's still not completely recovered. So pardon me if I have, some interruption due to cough. So as Dr. Tanuja, highlighted that the minute we hear the diagnosis of peripheral T-cell lymphoma, what comes in your mind as a clinician or as a pathologist is very similar. For a pathologist, whether you're really confident that you have identified the right subtype, whether you've identified that it is a lymphoma, because there is so much heterogeneity in terms of appearance of the same T-cell lymphoma between two patients. And definitely, there are differences in microscopic appearance between different T-cell lymphomas. And oftentimes there are mimickers, which are, not truly any malignant disease, but it's, it appears under the microscope that there is likelihood of T-cell lymphoma and vice versa. So that's a nightmare for pathologists, when they get to see or they put a diagnosis in not so clear-cut cases that it is T-cell lymphoma, and that happens quite often. When we talk about clinicians, again, getting a diagnosis of T-cell lymphoma, you're not truly very happy because, because the basis of diagnosis hasn't been very strong. You push your pathologist often to, put down on a particular subtype. And even once they are clear that it is T-cell lymphoma, you are not happy in majority of the times because, the outcomes are not going to be very good. So on the whole, you can say that it's a rare disease. If you look at all non-Hodgkin's lymphoma, it's around 10 to 15% of all non-Hodgkin's lymphoma, which are T-cell lymphoma. If you look at the WHO 5th edition, almost 30 distinct entities are part of this T-cell lymphoma subgroup. And there is a huge variation in terms of presentation. Some could be nodal, some could be extranodal, some can have leukemic presentation or a combination of all three, or they could be cutaneous lymphomas. And except for few, majority have poor outcomes even with treatment. So this is a slide which basically tells us about, on the x-axis, you have median age at presentation. On the y-axis, it's the median overall survival. And the size of the blob practically represents how common this T-cell lymphoma is. And the color represents whether it's nodal, non-nodal, cutaneous, leukemic presentation. So as you can see that, in relatively younger age group, you have this hepatosplenic T-cell lymphoma, subcutaneous panniculitis T-cell lymphoma, and ALK-positive ALCL. And they can, ALK-positive ALCL, we know that it can have nodal and extranodal presentation, whereas hepatosplenic T-cell lymphoma predominantly present with, liver and spleen involvement. If we go towards the other, relatively older age group, and that's where your nodal subtypes, that is PTCL, NOS, AITL, ALK-negative ALCL, all these become predominant. And you have some leukemic subtypes here like LGL and PALL, which are common. Some of these, T-cell lymphoma like enteropathy-associated T-cell lymphoma and ATLL are relatively rare, sometimes difficult to diagnose and misdiagnosed many times. And after a long gap, the correct diagnosis is made, and that becomes a challenge both for the clinician as well as, for the patient. And as you can clearly see here from this y-axis, that the median survival for some of these rarer ones is quite poor. It's less than 2 years, whereas there are some which are good, like LYP, where you have almost like 100% 5-year overall survival, and they go on for years altogether. ALK-negative ALCL, they do better, and the rest of them fall somewhere in between. So what I wanted to highlight from this slide that there are some which are relatively common, there are some which are rare, extreme, variable presentation, which can be seen with different outcomes. So though they are all clubbed together at T-cell lymphoma, they are actually each one of them biologically and prognostically a different disease altogether. And that we need to keep in mind while we are counseling the patients as well as planning treatment. I know I cannot cover all those 30 plus entities here. So I'm going to focus my talk on peripheral T-cell lymphoma, not otherwise specified. The category, which is in the WHO 5th edition, clubbed as nodal T follicular helper cell type of T-cell lymphoma, where you have 3 entities which are now part, that is nodal TFH AITL type, nodal TFH follicular type, and nodal TFH, which is not otherwise specified, which was earlier called as peripheral T-cell lymphoma with TFH phenotype. And I'm going to focus on anaplastic large cell lymphoma, both ALK positive and ALK negative, and extranodal NK T-cell lymphoma. If you look at the clinical features, though there is significant overlap with respect to some of these lymphomas, especially the PTCL and ALCL, the presentation can be very similar. However, there are subtle differences. And in the next couple of slides, I'm just going to highlight these important differences, which one can keep in mind while evaluating a patient who has suspected T-cell lymphoma or a suspected lymphoma. So anaplastic large cell lymphoma are more commonly seen in males as compared to females. Most of them have advanced stage of presentation. The ALK positive ALCLs have significant amount of extranodal involvement. Majority of these patients either have skin, bone, soft tissue, lung involvement at diagnosis or marrow involvement, and they typically have younger age at onset. As opposed to that, the ALK negative ALCL, even though here you see advanced stage of presentation, but the age of presentation is relatively older. So you're looking at the disease in 50s and 60s. So these are two important differences with respect to ALK negative and ALK positive. Having said that, it doesn't mean that an ALK negative ALCL cannot happen in somebody who's 30 years of age. So these are some of the descriptors which are typically a book picture description, but it's not that these diseases are restricted to an age group. It can happen at any age group, in this young adult to the elderly age group. One important point which I want to highlight, because that's where the clinical picture matters a lot, is cutaneous ALCL. So you may give a biopsy from a particular site to your pathologist, and they will report it as an ALK negative ALCL. Though there are features which can tell you on the biopsy that it is skin involvement and it could be primary cutaneous anaplastic large cell lymphoma, but it's important to give them a clinical picture that it's a single skin lesion with nodular lesion, ulcerated lesion. There may or may not be regional node involvement. And if you get the ALK negative ALCL in this setting, you know that you are handling a primary cutaneous ALCL, which only requires local therapy. You may not need any systemic therapy. So it's important to provide this information to your pathologist that where this biopsy is from, what are the clinical picture you are seeing, and that will help them in making a diagnosis. And for you, it's important to look at whether there is any evidence of systemic disease beyond the regional nodal involvement, which can come up after multiple relapses. You need to make sure that you tell your pathologist, that we have done the systemic workup and there is no other disease site which we are seeing in these patients. So this is something, important for ALCL. If you look at all the nodal, T follicular helper cell type peripheral T-cell lymphomas, most of these lymphomas are present in elderly with advanced stage of disease. They have generalized lymphadenopathy, hepatomegaly, splenomegaly. You can have pleural effusions, ascites. They will have, they're relatively sick majority of the times because of the fever, weight loss. They may have arthralgia. They may have skin rash. All these symptoms are there. And when you do their blood workup, you would find that the albumin globulin is reversed. They may have Coombs positive hemolytic anemia. They may have other autoimmune manifestation because you may have rheumatoid factor, which is positive. You may have ANA, which is positive, and they may come up with one or other, autoimmune phenomena, which are common. So many times, when you have this kind of a picture, with generalized small lymph nodes all over, relatively sicker patients, elderly person, with all these autoimmune manifestation, then in that case, you are relatively certain that there is likelihood of, the AITL subtype or the nodal TFH AITL subtype is likely. So these are the, some of the clinical features which you see in these patients. Coming on to PTCL, nothing very specific, but more important here is that it can be only nodal or it can be nodal plus extranodal presentation. It's relatively less common to have limited stage peripheral T-cell lymphoma not otherwise specified. Most of them have advanced stage disease. At presentation, many of them may have pruritus, they may have eosinophilia in the peripheral blood, and they may present with hemophagocytosis. So they may be quite sick with significant high spiking fever, cytopenias. All this can be because of the underlying hemophagocytosis, which is there in these patients. A very interesting T-cell lymphoma is extranodal NK T-cell lymphoma, and almost 80% of these patients have nasal disease. And by that, I mean that, you may or may not be able to find a nasal primary on a clinical examination, and you would need to do an imaging to make sure that there is a, nasal primary in terms of a PET scan to document that. 20% would be non-nasal. And when I say nasal, it doesn't mean just the nasal cavity. It could be, paranasal sinus. It could be upper digestive tract involvement. So it can be any of this site. The 20% are purely non-nasal, where you cannot document a nasal primary. And the sites could be skin, it could be gastrointestinal tract, it could be testis. This particular disease, because of the angiocentric invasion, they typically have mass lesion with a lot of destruction, ulceration. So you typically get to see a patient who has, either epistaxis, there is a, mass lesion with, local destruction, as well as you may find a perforation. They may have palatal perforation, which is present because the disease has gone on for a relatively long period of time. And similarly, you can see these at other sites also. If there is skin involvement, again, an ulcerative lesion, which you can find because of the angiocentricity in this particular lymphoma. And again, here you can have hemophagocytic syndrome. So these are some of the typical clinical features which are seen. How do we diagnose? And that's something which is very, very important. And what Dr. Tanuja was highlighting is many times, these are mimickers and you may not be able to get the diagnosis in one go. You may need repeat biopsies, and which can be frustrating both for the clinicians as well as for the patient. So it is very important to consider if you have a whole node biopsy or an incisional biopsy, so that your architecture is well preserved when your pathologist is evaluating. So very important, instead of just doing core needle biopsies, you need to consider a whole node or an incisional biopsy. Core needle biopsies only if you don't have anything in the periphery which you can easily biopsy. Please do consider whole node or an incisional biopsy. While we are here at the need for biopsy, a very important point to note that NK T-cell lymphoma, you can have repeated biopsies negative, for the reason being that you have predominantly necrotic lesion and you may not have enough tumor cells to, get your diagnosis, or the pathologist to, even get a morphological picture, run an immunohistochemistry. So it's very important that if you have clinical suspicion, make sure that you speak to your surgeon or the person who's doing the biopsy that, this is what I'm suspecting. Please consider for, multiple biopsies from that area or a deeper biopsy, so that we'll be able to get that answer. So what I'm trying to highlight, don't get frustrated if you don't get diagnosis in a single biopsy. It happens very commonly in T-cell lymphoma, especially the AITL, where we have seen that, there are series of biopsies which are there, and then somebody gets to, call it as AITL or the current one that is nodal TFH AITL type. So always make sure that you discuss with your pathologist, understand the challenges, and then come back and do a repeat biopsy. You would need an extended panel of immunohistochemistry. This is a place where a lot of things have changed over a period of time, and therefore you do need an extended immunohistochemistry panel. One word of caution: most of us think that T-cell gene rearrangement is something which is the diagnostic criteria for T-cell lymphoma. Answer is no. You can have T-cell gene rearrangements in some of the proliferations, some of the totally non-neoplastic disorders, and in the lymphomas, you may not find T-cell gene rearrangement always. And the clear example for that is you have, NK T-cell lymphoma, because you have many of these are NK cell origin, and you may not find a T-cell gene rearrangement. You may find IgH gene rearrangement rather than T-cell like in AITL. So it's not that it's pathognomonic for T-cell lymphoma. You can find in non-neoplastic disorder. You may not find it in T-cell lymphoma. And, these are the things which you need to keep in mind. So it's the pathology, the histomorphological appearance, the immunohistochemistry, and the overall clinical thing, which, helps us in making a diagnosis. T-cell gene rearrangement can supplement in some of the cases that what you're handling is a T-cell lymphoma. I'm taking the risk and describing the pathology in front of a pathologist for few of these lymphomas. So Dr. Tanuja, please feel free if you feel that anywhere I'm not doing a right job. So I'm just going to take one by one all of these, because these are important to understand. Because what I want all of you not to just read the impression which is given by pathologists, but the entire description. What is the appearance, the microscopic appearance which is being described? What is the immunohistochemistry? And see whether that matches or not. And that make sure that it's a single place where both the morphology and IHC has been done, because IHC interpretation is largely dependent on that. So it's very important to read the pathology report in entirety, especially in T-cell lymphomas. So typically you have this anaplastic large cell lymphoma, and we know that there are several subtypes based on the morphological appearance on the HNE. You can have a common subtype, which is almost 60%, lymphohistiocytic, small cell, Hodgkin-like, which can create challenges in differential diagnosis with Hodgkin's lymphoma and composite type. You do see these large cells. The common one has, these cells in sheets. There is sinusoidal invasion, which is present. We call them as hallmark cells. But what I just want to tell you that, this is all good for us clinicians. When we read the books, we find these cells very, peculiar, and we feel that why pathologists cannot see these cells, but sometimes it's not so clear under the microscope. And unfortunately, the lymph node biopsy has not read the textbook, and therefore you may see a, different appearance. So important point in anaplastic large cell lymphoma, when you are looking at the immunohistochemistry, the strong CD30 positivity, the diffuse membranous positivity, which you see in anaplastic large cell lymphoma, be it ALK positive or ALK negative. And you may have T-cell markers which are negative. So it may be CD3 negative. You may find CD2 being positive, and the aberrant loss of other T-cell markers like CD5 and CD7. These are usually cytotoxic marker positive. Anaplastic large cell lymphoma, you can have EMA positive. You can have, the perforin, the granzyme, the TIA1, all those can be positive here. I'm sorry for the typo, it's EBV, and these are usually EBV negative, lymphomas, which when we talk about anaplastic large cell lymphoma. The only difference between ALK positive and ALK negative is the staining for ALK. And in ALK positive large cell lymphoma, depending on what is the underlying lesion, the genetic lesion, ALK has translocated with what, the staining pattern for ALK may vary. For the commonest one, that is, NPM1 ALK, it's membranous, it's cytoplasmic and nuclear staining of the ALK which you see, and otherwise you can have any combination or membranous, staining for ALK1. So if ALK positivity is there and all these features are there, then you call that as ALK positive large cell lymphoma, and they do much better as compared to any other T-cell lymphoma. In fact, their outcomes, if you look at International T-cell Lymphoma Project, are almost similar to the diffuse large B-cell lymphoma. Coming on to the ALK negative ALCL, it's very similar to what is, in terms of morphological appearance and the pathology and the immunohistochemistry as ALK positive, except that they are ALK negative, they don't stain for ALK. But an important point here is that this is not one disease. Again, we know that now with the the studies, the gene rearrangement studies, that there are 3 subtypes of ALK negative ALCL. One, what we call as DUSP22 positive, the other one, which is TP63 positive, and then you have, which is, obviously the triple negative, meaning negative for ALK, negative for DUSP22 and TP63. Why it's important? Because we know that DUSP22 has a very, excellent overall survival, almost similar to what you see in ALK positive ALCL, versus those who have TP63 have, overall survival as per this particular study documented at less than 20%. So that's why it's important to, differentiate between these two, because you will be able to prognosticate these patients better. You can avoid using intensive consolidation therapy in these patients in terms of autologous stem cell transplant, because with chemotherapy itself, they are going to do well. Can you, try, so we do DUSP22 by FISH, but, can you look at some of these morphological features and think of that it could be DUSP22? Answer is yes, you have these donut cells as well as, the less of EMA positivity and no cytotoxic pattern, which you see in these cells. And that is an indicator that it could be DUSP22, but you do need to confirm it by demonstrating the rearrangement. Another challenge which comes in is differentiating the ALK negative ALCL with PTCL NOS. They can be very similar under the microscope. In the next slide, I'll show you that, what a PTCL looks like, and, typical PTCL, what all markers can be positive. But it's important to differentiate between the two. And the reason being that, the outcomes for ALK-negative ALCL are better than peripheral T-cell lymphoma not otherwise specified. And therefore, it's an important, pointer to remember that, it's just not for the sake of pathologists or troubling the pathologists that they need to give us the correct diagnosis or correct subtype. It's important to know whether you are handling an ALK-negative ALCL or a PTCL NOS. Coming on to the PTCL NOS, as the name suggests, it's not otherwise specified. So it's in a great sense, it's like a diagnosis where anything which doesn't fit in other subtypes comes in here. And to make matters worse, you have a whole lot of different morphological spectrum of peripheral T-cell lymphomas, which are in this NOS category. So you can have, pleomorphic, or you can have small cell type or large cell type. And these are usually, positive for T-cell markers like CD2, 3, 5, and 7, or they can be an aberrant loss of one of these antigens, mostly 5 and 7. They're usually CD4 positive, CD8 negative, but the other scenarios can also be seen. And CD30 here is, what we said in ALCL, that it's strongly positive, but if you look at the PTCL NOS, the CD30 positivity is weaker. And that's something which helps in differentiating in certain cases whether you are handling the ALCL ALK negative or PTCL NOS. Things have gone a little beyond in PTCL NOS because the gene expression profiling studies showed that there are two kinds of PTCL NOS, one which are driven by TBX21 and have TH1 phenotype. And the other one is GATA3 driven, PTCL NOS, which has, different immunohistochemical profile. And these are important because their outcomes are different. TBX21 does better as compared to GATA3. And more differentiating this is going to be important because there is some suggestion that we can move towards biomarker-driven therapy. And at our center, we are planning a trial, for these biomarker-driven therapy in patients who have peripheral T-cell lymphoma. And those who do not have TBX21 or GATA3, they are all, clubbed together in that waste basket, which is PTCL unclassified. And you have here the cytotoxic subtype, the Leonard's, etc. They all come in this unclassified type. So this is a study which looked at different cutoffs for T-cell markers and the CD30 to see whether you are handling an ALK-negative ALCL or PTCL NOS. And as you can see clearly that except for CD30, which is strongly positive in ALK-negative ALCL, and to a certain extent, stronger CD3 positivity in PTCL NOS, others are not really very helpful. So you have, other markers which may or may not help. So it is a diagnostic challenge in many cases, but it's important to put this differentiation down in the report. Moving on to the, one of the most difficult diseases is, what has become now nodal TFH is the AITL, because you can have a node which is almost looking like a normal node with some aberrations to a node which is diffusely involved by these small T lymphoid cells, and you have these high endothelial venules. So you can have a very textbook kind of a presentation, an easy diagnosis versus something which will look like almost like a PTGC under the microscope. And it's only over a period of time that you'll realize that you're not handling with the PTGC, you are basically handling the ITL, which is in a different presentation, morphological presentation. What is important here is that these are, other than the T-cell markers, so these are CD3 positive and the other T-cell markers positive, these are CD4 positive. And you do need to have more than 2 TFH ICs documented here. That's required for diagnosis. And you have, TFH markers, if we talk about, you have CD10, you have PD1, you have BCL6, CXCL13, ICOS. So you need to have more than 2 TFH markers, which are to be demonstrated in these CD4 positive T cells, other than the morphology which you are looking at before you call these as nodal TFH lymphomas. A difficult thing to do many times, especially if it is not like a diffuse involvement, if it's only perifollicular involvement. Within these TFH, nodal TFH lymphomas, you have 3 subtypes. And what is common is in terms of their morphology, what is common is that they're all derived from the T follicular helper cell subtype of T cells, but there can be important differences in their morphological appearance. What I want you to see is that most of them have these molecular signatures. That is, TET2, DNMT3A, ROA mutations, which are positive. In AITL, you do see IDH2 mutation. It was more of a biological understanding that these markers were identified, but as we can see in later on in the clinical scenario and the treatment, they will probably become important over a period of time when we are going to select cases based on the presence of these lesions, and you can treat all these three entities in a similar manner. So this is something which is what you see in NK T-cell lymphoma, and it's important to remember that this 80% of these NK T-cell lymphomas have NK cell lineage, and the remaining 20 would be from T-cell. And you may see a cytotoxic profile. The CD3 here is negative. The surface CD3 is negative. You can have a cytoplasmic CD3. You have CD56 positive, 16 positive. And these are the T-cell lymphomas where you see a lot of angiocentricity, angioinvasion, and you may not be able to document the T-cell gene rearrangement if you are looking to do so because they are NK cell origin. So that was all from my side for pathology, and I'll be happy to take it with Dr. Tanuja if she feels anything which I haven't explained well. So coming on to the workup. So once you have this diagnosis, you would want to have a complete workup in terms of complete blood counts. Because as I said, that these patients may have leukemic spill, not so much so in the types of lymphoma what I have spoken about, but you have other T-cell lymphoma where you can have leukemic spill, and in that case you do need to do a peripheral smear, and you would get your answer on flow cytometry. In anaplastic large cell lymphoma, you can see paraneoplastic leukocytosis. It's predominantly neutrophilic leukocytosis. If you have HLH, then in that case, you can have cytopenias. And if you're looking at AITL or nodal TFH lymphomas, you may find hemolytic anemia here, and you may find rouleau formation if you're looking at your peripheral smear. Biochemical parameter documentation is important. ALCL, ALK positive, can have hypercalcemia. You do need to do serum LDH for the prognostication as well as the viral markers because it will have your therapy implications. And amongst the viral markers, though I have not spoken about ATLL, but if you have rest of the morphology which indicates towards ATLL, doing HTLV1 and 2 serology is important because that will help in making the confirmed diagnosis. Evaluate for HLH, anyone who has B symptom cytopenias, make sure that you do all the parameters for HLH to document that there is HLH. One, because these patients require an early treatment because they're usually very sick. And second is that when the relapse happens, many times they start presenting as HLH even before you are able to document a relapse with the nodal biopsy or in terms of imaging. Most of these lymphomas are FDG-avid, except if we talk about the cutaneous T-cell lymphoma. These are all FDG-avid lymphomas, and therefore PET-CT is important staging workup. More so because many patients have a lot of extranodal involvement, so it's important to do a PET-CT. For the NK T-cell lymphoma, where there is nasal NK T-cell lymphoma, you want to document the local invasion, and because your treatment would involve radiation sometime down the line, so you need to have your local disease documented well. So it's important to consider for an MR for the paranasal sinuses to have the disease extent documented clearly. Again, in NK T-cell lymphoma, it's an EBV-driven lymphoproliferative disorder. It's important if you have means to do EBV DNA because it tells you what's the disease burden. So it has a prognostic role as well as with therapy it declines. And if you start seeing a rise, then it's an harbinger that your disease is coming back. So EBV DNA levels, EBV DNA PCR is important if you have means to do that. Bone marrow aspiration and biopsy is required in all patients because PET-CT does not have a very good negative or positive predictive value. So in that case, it's important to do a bone marrow aspiration and biopsy. again, an important point from the NK cell lymphoma, you may not see the, the malignant cells in the bone marrow, but you may find Eberish positive here, and that's an indicator that the marrow is involved. So it's important to consider Eberish on the marrow to say whether there is, bone marrow involvement or not in patients who have NK cell lymphoma. There are a whole lot of prognostic scoring starting from the IPI, which was used for any aggressive lymphoma, including the B-cell lymphoma, to something which has become more and more specific towards T-cell lymphoma, like, prognostic index for T-cell lymphoma, that is PIT, which had removed the extranodal site from IPI. And instead, there was bone marrow involvement. Instead of taking the stage 3, stage 4, it was only bone marrow involvement, which was accounted for. And there were 4 groups with varying outcome, varying from less than 20% to more than 60%. Then the PIT was modified, and by removing the bone marrow involvement with something which is more representative of disease biology, that is Ki67. So that was modified PIT. And again, here we have 3 risk groups. Then to improve on this further, International T-cell lymphoma project identified an international T-cell index where, something which is more easily available, that's platelets. Instead of Ki67, it was platelet which was put in. And based on this, there were 4 risk groups. Then there is a T-cell score, which again takes the clinical and the biological parameters starting from stage, performance status, albumin, and ANC. And you have, 3 risk groups which are defined. So is there anything which is better than the other? So most of these have been validated with the earlier therapies, not validated with the novel therapies. And amongst all this, the International T-cell lymphoma prognostic index seemed to perform better as compared to the others. And as you can see that most of these parameters would be easily available to prognosticate. But are you going to decide your treatment based on that? Answer is no. And we'll come to NK cell lymphoma. There is a entirely different set of prognostic indices which are available for NK cell lymphoma. So as of now, it only tells you that your conventional therapy, CHOP and CHOP-like therapy, what you do, and if you have this, prognostic index, what's the outcome which is going to be there. So that's the value of these prognostic indices as of now. Moving on to the treatment. So we know that, CHOP was considered as, one of the regimens for all the aggressive non-Hodgkin's lymphoma, not segregating B and T cell from the earlier data, and they were better as compared to any other intensive therapies which were compared with CHOP. If you look at specifically for T-cell lymphoma, peripheral T-cell lymphoma, so this is the meta-analysis of all the data which was available before 2011 for how effective CHOP is for PTCL and different subtypes of PTCL. So what we can see from here that it is not really what we want for these patients, not what has happened in diffuse large B-cell lymphoma, that addition of rituximab has changed things a lot. Unfortunately, CHOP seems to be the only option here till this meta-analysis, and almost half of the patients show complete response. And within different subtypes, the ALCL ALK positive, they do better. And the AATLs, that's the entropathy-associated T-cell lymphoma, they do worse. The rest fall somewhere in the middle. If you look at AITL, it's roughly around 30% long-term survival if you treat them with CHOP. For the peripheral T-cell lymphoma also, it's roughly around 38 to 40%. So a lot more is desired, more than CHOP, to improve outcomes in these patients. What attempts were made after this? People use gemcitabine-based therapy, so combining platinum, gemcitabine with high-dose steroids, comparing it with CHOP, no difference. You got more toxicity, but there was no benefit. There were drugs like bevacizumab combined with CHOP, again, no difference. Then you had, alimtuzumab, which was combined with CHOP. Again, there were some better responses, but none being very durable. So basically a very frustrating experience, when you say that what has changed from CHOP till now, not much, except, few which stand out a little differently is, one is the addition of etoposide. So this was a retrospective study from the German, group. And here, if you look at this, they used CHOP and CHOAPE. And if you look at the CHOAPE data, the etoposide addition helped 3 categories. One, those who were less than 60 years, normal LDH, and ALK-positive anaplastic large cell lymphoma. If you look at older individuals, those who had raised LDH and non-ALK positive subtype, the benefit was not much. So you're only adding toxicity. Having said that, there was trend towards significance in the nodal PTCL, other than ALK positive ALCL, the nodal PTCL, there was a trend towards significance. But if in strict sense you want to read this analysis, it's only 3 subgroups where addition of etoposide really helps. And based on this, there's some little data for dose-adjusted epoch in patients who have T-cell lymphomas, and it has shown some improvement in responses, but it's a single-arm, small study, so not much can be read into that. But no comparison with CHOP there to see that whether that results in better outcome. Then came along, the brentuximab vedotin for the CD30 positive lymphoma, almost 450 plus patients. 75% being ALCL subtype, the systemic ALCL subtype. And as you can see that the long-term follow-up, which has come in, a year back, 2 years back, showed that there is definitely an improvement in overall survival as compared to CHOP when you use brentuximab. But was it true for everybody? Answer is no. So the benefit was largely confined to the anaplastic large cell lymphoma, whether you talk about ALK positive or ALK negative. If you look at other subtypes, the benefit is not there. Though most of the people extrapolate this data and continue to use brentuximab in PTCL NOS and in AITL, we need to use this with caution because the numbers, as you can see here, for the PTCL subtype are really, really small in the brentuximab, and same is true for the AITL, that you have a less than 40 patients who are there in AITL. And another important criteria for study entry was CD30 staining should be more than 10%. And we know that AITLs do not have very strong CD30 staining in majority of the neoplastic cells. So we need to be very careful before we recommend BV along with the CHP in these 2 subsets. For ALCL, answer is yes, but for others, I do not think that it has proven its value. As I said that, we've understood the molecular biology better, and we know that, if we look at the nodal TFH subtype, that you have a lot of epigenetic dysregulation because you have your TET2, your DNMT3A, ROA mutations, and which result in DNA methylation. And these DNA methylation patterns are responsible for chemoresistance. So can we use something to reverse this chemoresistance? And this was tested not for any specific subtype of PTCL, but it was, non-selected PTCLs. And here, oral azacitidine was given as priming for first 7 days and then CHOP. And from cycle 2 onwards, the oral azacitidine was given for 14 days prior to the cycle 2. So this is something which has led to important, understanding. It's a small phase 2 trial, but it did result in improvement in complete response rate as compared to historical data and the progression-free survival and overall survival. And the benefit, if you see in terms of CR rate, was remarkable in the group which had TFH phenotypes. So probably, instead of treating everyone in similar way, from this, we can think of that we can biologically select these patients who have TFH, nodal TFH subtype of lymphoma, and consider treating them with oral AZA and CHOP. But again, we need to be careful. This was a phase 2 data, and we know that many times the phase 2 doesn't really translate into what we have seen in phase 2 and phase 3 trials. And this is what has happened with romidepsin, where combination of romidepsin CHOP versus CHOP did not show any improvement in PFS, which was the primary endpoint. So the study was a negative study. Again, here, my concern is that we have treated everyone in the same manner. It was not a biologically selected group, and therefore, not all epigenetic therapies will be helpful if that is not the factor driving the molecular pathogenesis. Moving on to the last section, what is the role of transplant, whether you should be thinking of transplant or not, why, and auto and allo transplant. So basically no phase 3 data again. You have all phase 2 studies as well as registries which are there. And if you look at the data from different phase 2 trials, except for one which was the largest study, I'll show it a little later, most of these have included anaplastic large cell lymphoma, except for this, particular study, which was the NILG study, and you don't have an ALK positive ALCL. And why I want you to remember this, because ALK positive ALCLs do better. And again, the criteria for transplant were that they should be having a chemo-responsive disease, and not everybody who was decided for transplant proceeded with transplant, and you have failure rate of almost 1/3 that they were not taken up for transplant. But what is important is to show, as compared to what we saw in the CHOP alone data, that the progression-free survival and overall survivals seem to be better as compared to not doing the consolidative stem cell transplant. If we look at the data for allogenic stem cell transplant, again, the phase 2, the concern here is the outcomes are almost very similar to what you are seeing in the autologous stem cell transplant, but a high transplant-related mortality as compared to what we are looking in autologous stem cell transplant. This is some of the registry data, and the latest one which is there is from the complete database which is there. And again, here this includes anaplastic large cell lymphoma with predominantly ALK negative being there, and you can see that at 2 years both the OS and the progression-free survival are better. If we look at this particular complete database, the complete database which looked at autologous stem cell transplant in these patients, the AITL subset benefited maximum as opposed to the others, versus if you look at the NLG trial, here the benefit was predominantly for patients who had ALK negative anaplastic large cell lymphoma. The benefit was there for others, but the ALK negative ALCL stood out as amongst others. So the answer is anybody who's otherwise fit for autologous stem cell transplant, has chemo-responsive disease, should be considered for autologous stem cell transplant if they have ALK negative ALCL or AITL, and to a certain extent, probably a PTCL NOS. So these are the groups where we should think in terms of if the outcomes, they have advanced stage disease, and if we don't do anything, the outcomes are going to be poor. And therefore, even though it's not a very high quality data, it does indicate that autologous transplant is probably going to result in durable responses. Moving on to the role of radiation in these patients, very limited data. Once the limited stage disease as such is very less in PTCL NOS. And even there, the studies are predominantly an extrapolation from the diffuse large B-cell lymphoma. So that's where you use combined modality therapy. For advanced stage disease, the role for consolidative RT, there is no specific data to suggest benefit of consolidative RT. But yes, this is a very small study, and you can clearly see that combined modality therapy is better as compared to doing only chemotherapy. So somebody with stage 1, stage 2 disease, you can think of giving radiation as combined modality therapy along with your CHOP, what you have given as initial therapy. Several therapies are being evaluated because we know it's a disease where relapses are very common. The initial responses are usually short-lived, except for pralatrexate and to a certain extent romidepsin. Most have not really helped. So except for brentuximab, which we have already seen that there is some data in the frontline therapy. For majority, the data is the responses are limited. But if we look at the complete database again, and if you compare the targeted therapy versus second-line chemotherapy, targeted therapies seem to give better responses and more durable responses. And the combination of targeted therapy seem to do better. So meaning combining romidepsin with azacitidine can result in better responses, but a field which desires a lot. So, but these are the things which can be thought of. We do have availability of oral azacitidine now with us, and that can be explored. So the last section, for the lymphoma is, now I'm going to just switch gears and talk about NK T-cell lymphoma. It's different than other, T-cell lymphomas, starting from its staging. So we know that, the treatment here involves radiation also, and, it's important to document the extent of disease, not how it is listed in the, Ann Arbor staging method, or for that matter, the Lugano staging. You do need to do staging in very similar manner as you do for a solid tumor. So that's where the difference comes in. And this is a new Chinese Southwest Oncology and Asia Lymphoma Study Group staging system, which basically accounts for presence or absence of local invasion, whether there is regional node involvement or not, and whether the disease is disseminated beyond the local regional area. And based on that, you have these different staging categories. The prognostic scoring here is different. You have KPI, that's Korean Prognostic Index, you have PINC, and you have the NRI. So these are several scoring systems. Most of these have been validated even in the elasparaginase-based study. And the common ones which are being used are PINC and the NRI, which are being used while evaluating these patients. How do we treat them? If you have a newly diagnosed NK T-cell lymphoma, first and foremost, based on the staging system, whether it's a limited stage disease or an advanced stage disease, and second, whether the person is fit or unfit. So if somebody has limited stage disease and not fit for systemic therapy, you can only give radiation. And here the dose of radiation is much higher than what we see in lymphoma. So we talk about here radiation in the tune of 65 to 70 grade, just like how you give it in the solid tumors, as opposed to the other lymphomas where we use 30 to 35 or 40, 45 grade, depending on partial response or complete response. But if you have a fit patient and limited stage disease, you need to think in terms of combined modality. And that combined modality can be SMILE, or you can use concurrent cisplatin along with radiation. And once the radiation is over, you can consolidate with the DEVIC chemotherapy, or for that matter, PGMOX. So you basically bring in radiation early on so that you take care of your local disease, and then you can think in terms of consolidation. That becomes a challenge when you are doing a SMILE kind of therapy, because you have high-dose methotrexate. And once you already have given radiation, giving high-dose methotrexate-based therapy becomes extremely challenging because of the mucositis. So if you're using anything which has high-dose methotrexate, you complete that, then bring in RT. If you're using something which is cisplatin, elasparaginase, gemcitabine kind of a therapy, ifosfamide combination, whether you're talking of PGMOX, PGLOX, or you're talking in terms of DEVIC, you can bring in radiation earlier, and then you can or you can bring in radiation as a sandwich, and you can give chemotherapy before and after. For systemic disease, meaning wherever we are talking of stage 3 and stage 4 disease, depending on whether they're fit for high-dose methotrexate-based therapy or not, you can decide giving SMILE, or you can use PGMOX, you can use PGLOX, you can use DDGT. So there are several options, but it's important to consider using a set of regimen in your setting rather than bringing in variation for every patient, because the reason is then you have more confidence, you know how to anticipate those side effects, and you have your data in a uniform format, and that gives you important learning as you go ahead. So these are some of the things which we need to keep in mind for NK T-cell lymphoma. So I'll just close this by saying that it's one disease, meaning almost all disease you require discussion with pathologists, but this is one disease where a close discussion with pathologists makes a whole lot of difference. Subtyping is important, as you saw in the NK T-cell lymphoma. There are subtypes where you do need to tailor treatment. There is a future for targeted therapies based on the biomarkers, especially for the nodal TFH lymphomas, which one can think of. And with that, I thank you. I'm happy to take if there are any questions.
Thank you so much, ma'am, for that wonderful lecture. It was really eyes through every NK cell lymphoma, peripheral T-cell lymphoma. Thanks a lot, ma'am, for giving us the whole insight. Thank you so much. We'll start with the question answer session now, ma'am.
Sure.
So I request all the discussants to please put the raise hand signs. So yeah, Dr. Roshni Pandey, your question, please.
Hi, Manju.
Hi, Roshni.
Thanks for that wonderful lecture. It's a very difficult disease to handle. My question is, in elderly patients with poor performance status, say with ascites and cytopenias, either with or without hemophagocytosis, how do we treat them? Should we treat them? Should we actually treat them?
Yeah, your histology is PTCL, right?
Yeah, PTCL.
Yeah. So if if you're looking at somebody who's, again, elderly has a very vast sort of, spectrum. Sometimes even a 60, may look like really frail, especially if they've had if they have a lot of coexisting comorbidities, which are poorly controlled, and their, performance status 4, versus, you may have an 80 who's in the similar boat. So I think it's very important to look at how things were for that patient before the start of the illness. And if we feel that, they were otherwise doing things on their own, they were reasonably active, and all this deterioration in the performance status has happened now, since the onset of illness, I would still feel that we should think in terms of starting therapy here. You do have the opportunity to give a cycle in a modified doses and see whether there is an improvement or not. And if there is no improvement, then you can think in terms of palliative care. That's something which can be done. We do see many times this in AITL, that they are really sick, they have ascites, effusion, not so much in PTCL. We do see this in AITL, that they have a lot of ascites, effusion, they're really sick. And what we have seen, sick in the sense they have fever and all the constitutional symptoms. Many of these patients have CMV reactivation, because there is T-cell, immunodysregulation in these patients, and they have, concomitant CMV reactivation. And you start them on ganciclovir, their general condition improves, and then you can bring in therapy. Again, not possible to treat with very intensive, strong chemotherapy here, but you can bring in, and we have used things like oral cyclosporin in these patients, and they have done for some period of time, not curative, but yeah, they have done, well for some period of time. So I think this is one place where there is a whole lot of customization required, as opposed to, DLBCL, where we say, okay, you start with prephase and then you begin and give R-CHOP. A lot of customization is needed as you evaluate them, as well as you administer therapy. But if you see that they're not tolerating the first cycle of chemotherapy at all, even in the modified doses, then I completely agree that we take away the option of chemotherapy. Think of, if you're AITL, then in that case, you can think of things like cyclosporin. There's some data for even lenalidomide in these patients, but personally speaking, I haven't used lenalidomide in frontline in any of these patients.
The second question is, I have an ALK positive ALCL. He did well on CHOP, and then he relapsed about 2 years later, tried GDP. He was not a candidate for transplant financially. Then he didn't respond to 3 cycles of GDP. So there was nothing else to do but put him on vinblastine. Now he was given vinblastine weekly, and then thereafter 2 weekly. And he's on this for 1.5 years. I'm afraid to stop it. So how long should I continue? There's no toxicity so far. What to do?
So that's, that's a data from the pediatric setting that, alpha positive ALCL in the relapse setting, you can use vinblastine in these patients. And we have had patients, and not only just the pediatric patients, we have had a 54-year-old male whom we continued on vinblastine, and he continued to show, complete response. So these are all, one-off cases which we keep seeing. But what I feel that, if you've finished your almost a year of therapy in this patient and the disease remains under control, I think you can safely observe now.
Okay, the third question is this 37-year-old male was an NK T-cell lymphoma stage 3. It was the first wave of pandemic, so we gave Gelox with L-asparaginase followed by radiation. He was fine thereafter. In fact, he came to TMH also for follow-up. And thereafter, he developed CA alveolus in December 2022. He has undergone surgery. It's a PT2N0 lesion. Now, he developed PUO after that. He was re-explored on antibiotics. They found nothing. He received cefperazone, sulbactam, metrogel, then piperacillin, tazobactam, metrogel, and then transferred to me on meropenem, teicoplanin. The cultures are negative. The procalcitonin is negative. Ultrasound for Candida is negative. HRCT, there's nothing there. Bone marrow aspiration was done because we wanted to look for hemophagocytosis for malaria, for cultures, and for atypical cells. So all we get is some 20% atypical lymphocytes. The bone marrow biopsy has been done. The question is, should we do a PET CT and rule out disease before we try antifungals? He's having high spiking fever, but otherwise he looks fine.
So my concern here, Roshni, how you're describing is very high likelihood of this being an HLH. rather than, and you may not be able to document hemophagocytosis always in the marrow. And that's not the, mandatory criteria for saying that it is hemophagocytosis. So my suggestion is that we work him up for the, hemophagocytosis fully. And if there is HLH, then in that case, do a PET scan, because to me, it looks like a disease rather than anything to do with a regular infection. And a fungal infection, if you are talking of a PTCL who's been treated with, something like Gelox, is something which is not, we are going to see now. Even though we say that most of these T-cell lymphoma patients have underlying T-cell dysfunction, which may last for a longer period of time, but that would be a very low probability, because we have seen so many T-cell lymphomas, NK T-cell lymphomas who've been treated even with, things like SMILE, and we don't see these kind of infections later on. So I wouldn't put it as fungal infection. My concern here is clearly that there is HLH, and we complete the workup for HLH and do a scan if there is HLH.
Thank you so much.
Thank you, Dr. Roshni. Dr. Stelling Bala, your question, please.
Yeah, good afternoon, madam. Very nice talk on the management of peripheral T-cell lymphomas. My question to you is, in ALK-positive ALCL, so what is the current role of using the ALK inhibitor either in the frontline setting and the relapse setting? So we recently had a case which came from an endorsement from an outside physician for the role of alectinib. The patient was started on alectinib for a relapsed ALK-positive ALCL. So what is your opinion on the current usage of these ALK inhibitors? We had a few experiences with crizotinib which induced CR, and later after some period of time the responses were gone. So what is your current usage, in which line you are using these ALK inhibitors, and what is your experience in using these ones?
Sure. So I'll just first, give what the data which is available. And the data is largely with crizotinib. So if you look at the data, which is there in the relapse setting, not for the frontline setting as of now, beyond the clinical trial. So if you look at the, use, which is where you have significant, considering that the numbers are in 20s and 30s. So that's where the data for crizotinib is. And it's actually quite, helpful, because you have responses, overall response rates up to the tune of 80 to 85%, which is quite remarkable in a disease which has come back, within a couple of years of stopping your definitive therapy. So in that case, it's really helpful. Coming on to whether other, ALK inhibitors are going to be better or not. So if you look at, what we have seen in the lung cancer, answer is probably that they are going to be, similar or maybe a little better than crizotinib. So anything which is available to you, and for us, many times the decision factors become whether there is availability of generic or not. So if you have availability, for that, and the patient can afford that, you can consider. But yes, it's only for the relapse setting as of now. I wouldn't recommend it because we don't have data to support it for the frontline therapy. Now, coming on to my own experience, it's n is equal to 1. So that's where my experience is in terms of using crizotinib, but that's in the relapse setting.
Madam, second question is, you told that the benefit of adding etoposide to the CHOP regimen is only for the patient who had a normal LDH and the patients who are younger in age. So now tomorrow morning a patient comes with a normal LDH who is young, fit enough to receive the 5-drug regimen like CHOP plus E. So would you consider it giving or we stick on to CHOP if the patient comes with a normal LDH?
So if you look at it, where I would prefer, as you were describing, and even somebody else said that, our ALK-positive ALCL, if you look at the International T-cell lymphoma project, their outcomes were actually better than diffuse large B-cell lymphoma. Unfortunately, we haven't seen that in our setup. Our ALK-positive ALCLs don't seem to do that well. And so therefore, today, if somebody is asking anybody who is beyond 25 years of age, and I'll come why I'm qualifying that. So, more than 25 years of age, ALK-positive ALCL, in that case, I would definitely use CHOEP. So that's something where I would definitely, recommend CHOEP. Coming on to whether I will do that for PTCL NOS with a normal LDH, less than 60 years, answer is yes, because I know that most of them don't have feasibility for adding brentuximab. And the data for brentuximab, I'm not very happy with given very small numbers. So that's another subset where I would consider using CHOEP. The third setup is whether there is an AITL who's in the same boat, that he is less than 60, he or she is less than 60 and having normal LDH, whether I would use or not. I'm not really sure, because that's not a subset where CHOEP has shown much benefit. So it's only for the PTCL because there was a trend towards significance, less than 60 years and ALK positive ALCL. So these are the only setup where I would consider using CHOEP, because I know that CHOP is not giving an answer, though I don't have a head-to-head comparison to say that adding etoposide is making a difference, but that's the best. Sometimes we get frustrated and we say that that's the best which we can offer, and in the frontline setting we give that best option which is available.
Thank you, madam.
Thank you, Dr. Stelling. Dr. Siddharth Ray, your question, please.
Yes, thank you. Thank you, ma'am. It was really nice lecture. I want to know, is there any role of interim PET-CT while we treat this group of lymphoma, PTCL?
So very pertinent question, because we keep doing interim PET scan in most of these patients, whether there is a prognostic role. Again, how it is established in diffuse large, meaning to a certain extent in diffuse large B-cell lymphoma and majority of the Hodgkin's lymphoma, that kind of data does not exist. Having said that, those who continue to have end of treatment PET positive, they do poorly. No brainer. We know that anybody who has not achieved a complete response is going to do poorly as compared to somebody who has achieved complete response. But for interim PET, the data is not available for almost all the PTCL subtypes as of now. But having said that, you really do an interim assessment, because you know that not everybody gets into complete response here. And if you have a progressive disease at the end of 4 cycles, you would want to change therapy. So in clinical practice, we only want to look at whether there is progressive disease or not. And that's what the interim PET is for, because here the CR rates are much lesser as compared to what we see in DLBCL or other B-cell lymphomas. So prognostic role is only for end of therapy. It's more from the clinical use that we do an interim PET to see whether there is progressive disease or not.
Another thing is that as I understand from your lecture, that even if PET is negative, at the beginning you want to do negative means PET is not indicative of the bone marrow involvement. You want to do the bone marrow aspiration biopsy. My question: if there is no cytopenia and PET is also not showing any hyperactivity in the bone marrow, then also you suggest that we should do the bone marrow with EBR ISH?
So I just want to delink the two things. One, we are talking of all the T-cell lymphoma other than NK T-cell lymphoma first. And PET does not have high negative and positive predictive value. What we mean by that even if the PET is not showing marrow uptake, there is a probability that marrow is involved. So if you want to do a complete staging workup, then in that case, you do need a bone marrow examination in all these patients.
Even without cytopenia?
Even without cytopenias. So you would do a bone marrow examination in all of these patients if you want to accurately label. Now, your question may come that whether it's a stage 3 disease or a stage 4 disease, my treatment is not going to change. So whether I really need to do a bone marrow or not. So that is something which we can discuss with the patient and say that this is the reason why we are avoiding marrow, because I'm not changing anything, unless you are using the modified PIT as your prognostic index where your marrow involvement is important. So based on that, you can decide whether you want to do a marrow or not at the beginning. But if you look at standard recommendation, yes, marrow examination is recommended. Now, coming on to doing EBERISH, that is only in patients who have NK T-cell lymphoma. And to say that the marrow is not involved, you need to have an EBERISH which is negative in those patients.
Okay, thank you.
Thank you. Dr. Satish Kumar, your question, please.
Thank you, ma'am. Enjoyed your talk. My question is regarding brentuximab. So where do you push, which CD30 positive lymphomas do you push for brentuximab? Of course, provided they're expressed more than 10%, where do you keep it as reserve? Should we some people may afford brentuximab. Should we push them for brentuximab in every patient who is more than 10% positive? And in those patients who have taken brentuximab, if the IPA score is high, should we take them for transplant? I'm talking about PTCL, NOS, or ALK negative ALCL.
So if you look at the data as of now, and this is, I'm talking from the Echelon 2 point of view, that, what exactly is there, the study has shown, the benefit is only in the ALK positive ALCL and ALK negative ALCL. And there were less than 50 patients if we talk about AITL and PTCL. So I'm not very confident suggesting brentuximab in these patients. So answer is actually only ALK negative ALCL, because we know that ALK positive ALCL, the comparator was CHOP, it was not CHOEP. So, and if you look at the data which is there available from CHOEP, it looks fantastic. So since the comparator arm was only CHOP, I would say that, if there is CHOEP, then in that case, I will use CHOEP in ALK positive ALCL. For ALK negative ALCL, I know that they do poorly, and that's a subset where, I would, if there is a feasibility to bring in brentuximab. Coming on to your question, whether they get into CR and we want to do transplant or not. So if you look at the study data, almost 70% patients were considered for transplant. So if you have complete response, and even in patients who were given brentuximab vedotin, if they are in CR and if they're otherwise fit, definitely an option of transplanting has to be given. Though the transplant, the censoring of the patients were done at the time of transplant, and the benefits still remain. So I think that gives again a suggestion that one should think in terms of doing transplant in these patients if they are fit.
So, ma'am, ALK negative PTCL give the option of brentuximab, and even after 6 cycles of brentuximab, CHP give them do the transplant. And post-transplant, any maintenance, ma'am, or on transplant in all IPA score or only in high IPA score, ma'am?
So see, when we are talking of these patients, we are talking of 99% of them are being in the stage of stage 3, stage 4.
That's true. That's
very few. It's like hardly 1 or 2 you would get to see in which are stage 1, stage 2 disease. So if you are early stage disease, then in that case definitely not, because that's an overkill probably. But if you're talking of an advanced stage 3, stage 4 disease, then in that case you should think in terms of consolidating with transplant for ALK negative ALCLs. And for PTCL, I'm not a big fan of brentuximab given the data. So, but in that case, if you have got into remission, then in that case again, and if the patient is fit, to think in terms of consolidative transplant.
Any role of maintenance anywhere, ma'am, in frontline setting?
As of now, there is no evidence for brentuximab or for that matter anything. Again, not a very scientific way of saying things till you don't have the data. But my very strong feeling is that all peripheral T-cell lymphomas require maintenance for the simple reason that, they all relapse within first 2 years. And, that's probably the reason that we have stopped their therapy pretty early. And that's the reason why they have relapsed. What maintenance is the biggest question. We need to think in terms of now with oral azacitidine coming in, whether for the nodal TFH subtype, whether this is a group where we can think in terms of maintenance. So that's one of the questions which we are trying to ask in our PTCL trial, differences in induction therapy based on their biomarker profile and different maintenance therapy based on the different biomarker profile. So these are 2 things which we are trying to address in that trial. It is still to start. We are, we've submitted for approval, so it will take time. Yeah.
Thank you so much, ma'am. Thank you so much.
Thank you, Dr. Satish. Dr. Ashish Bakshi, your question, please.
So, Manju, excellent talk. Is there any role of NGS in helping the diagnosis or prognostication of T-cell lymphomas?
So if you look at it, there are different subtypes which are driven by, different underlying biological abnormalities. So if you look at ALK negative ALCL, you can do both the things TP63 as well as does by FISH. You don't really need to run an NGS. And, same way you have these JAK-STAT pathways which are overactive in, some of these patients. The only subset where probably molecular subtyping will be helpful over a period of time is your nodal TFH, where you want to document the IDH, the TET2 and DNMT3 and, ROA. And you can only look at these markers rather than running an entire NGS profile, because as of now, there is nothing like one gene, one target here, which is going to be working. You're looking at whether there is epigenetic dysregulation by looking at all these 3 markers, and you see whether, you want to think in terms of adding oral AZA over the CHOP or not. and diagnostic. So sometimes you have these diagnostic dilemma, whether you are looking at PTCL or an AITL in some rare situation. And that's where if you document any of these mutations, the likelihood that it is AITL is much more as compared to peripheral T-cell lymphoma. So except for this small area as of now, I don't see that we need to do NGS in majority. Answer is no. Yeah.
And any role of immunotherapy in the management of T-cell lymphoma?
I purposely stayed away from there. So if you look at, immunotherapy has been a challenge, except for NK T-cell lymphoma. I'm not, that's a different subset altogether. But if you look at AITLs and some of the other T-cell lymphomas, immunotherapy checkpoint inhibitors have led to flaring up of disease, because we probably what you modified with immunotherapy has led to whatever little control the remaining T cells were having on the tumor was also taken away. Having those few of the earlier reports where this checkpoint inhibitors resulted in this problem, there are studies now evaluating checkpoint inhibitors in the PTCL and the AITL, but that remains always a concern that there will be a tumor progression because of the checkpoint inhibitors. For NK T-cell lymphoma, it's again one of the EBV-driven malignancy, just like Hodgkin's lymphoma. It's overexpression of PD-1, and that's where in the relapse setting, checkpoint inhibitors have a role, and you can think of checkpoint inhibitors followed by transplant. So that's something which can be looked at in relapsed NK T-cell lymphoma, whether it's nasal or non-nasal, and you can think of transplant after that.
Okay, one last question from my side. What would be the chemotherapy regimen that you would recommend for a young patient with subcutaneous panicular T-cell lymphoma?
So again, it depends on what you are handling with. If it is somebody who's just relatively limited stage disease, things like cyclosporin, even they work there. Somebody who has significant amount of HLH has not responded to any of these regimens, and even CHOP, or if it is a younger individual who's like in the pediatric age group, you can think of any of those pediatric intensive lymphoma protocols in these patients. But in our setup, we use things like cyclosporin or CHOP is what we give to these patients.
But is there any role of giving cyclosporin as maintenance after you have induced remission with CHOP?
Yeah, so as I said that, my personal feeling is that you need a longer therapy, but this is all my personal feeling. If I want to counsel a patient, I just can't say that, this is what I feel, because unfortunately there is no data to support that. Yeah.
I know, actually it's a difficult situation, because like I have a patient who responded partially to CHOP and not willing for transplant. So it's a really a tough situation on actually how to treat these patients.
So we all do some of these odd things every now and then, provided the patient is in confidence that, this is what we are doing, but we don't have data, but we feel that it is going to be helpful. We'll monitor you for toxicity and we'll just, continue this. I had a AITL patients for 2.5 years on oral cyclosporin, and I didn't have the guts to stop cyclosporin because he had really bad disease and he had responded. So, but after some time, I just took a call and we stopped. He's still doing well. So that's why I'm saying there are a lot of things which we don't know whether it's truly the cyclosporin which is working or it's just the previous therapy which has worked and it's still maintaining the response. So I think we do need to answer this in a coherent manner, but all of us do these odd things every now and then. So yeah.
Thank you so much.
Thank you, Dr. Ashish. Dr. Gopinathan, any question, please?
Good afternoon, ma'am. Thanks for the brilliant lecture. I really enjoyed every part of it. Like elderly man with AITL and presenting with a brisk autoimmune hemolysis. So how to manage these patients?
So, it depends on whether you can deliver therapy there or not. The reason why autoimmune hemolysis is happening is because of the disease per se. We've had such situations where people were very sick and we could not deliver the therapy, which therapy meaning CHOP. We couldn't deliver CHOP. So we've given them steroids. Some of them have shown to steroids. Second is rituximab, because you do have a significant amount of EBV positive proliferation which is happening. And this autoimmune hemolytic anemia several times shows response to rituximab. And then you can move on and you can continue with your regular therapy, which is CHOP, CHOEP, depending on what you can deliver looking at the patient.
This cyclosporin which you are talking about seems quite interesting. So how do we place that, ma'am, once after this CHOP?
So I am not promoting cyclosporin too much because the reason is that, I have to have significant amount of data. And as I was telling that these are, situation where n is equal to 2 or n is equal to 3. But, this is one disease where if you feel, man, this is again, I'm bringing in something which is so subjective, is that if you feel that the patient is otherwise not very, very sick, meaning the disease is not very aggressive, it's not, rapidly proliferating. You see these, small nodes all over. It's otherwise, he's having a lot of constitutional symptoms, and you have this hypergammaglobulinemia with a lot of autoimmune manifestations which are coming in. Probably this is a subset where you can think in terms of starting cyclosporin, more so because you can't deliver anything else in this person. But anybody who has an aggressive disease, significant nodal burden, it's very unlikely that it's going to work. So I don't know how to define that, that feeling which you get when you see a patient, but this is what I'm trying to objectively state, that, relatively low, small nodal disease, diffuse small, nodal disease with many of autoimmune manifestation you can think of. But please don't quote me anywhere that, how I got this feeling.
Sure.
Yeah.
Thank you. Thanks for that.
Thank you, Dr. Gopinathan. We have some questions in the chat box. Dr. Sumit Meg wants to ask that of CHOP regimen using vinblastine instead of vincristine.
So, Sumit, absolutely. We did try this in MH sometime back. We thought whether instead of giving vincristine and CHOP, we can use vinblastine day 1, day 8, day 15, taking the data from the relapsed, ALK-positive ALCL, which is there in the pediatric setting. The unfortunate part in most of the adults was that they couldn't take the next dose, that is day 8, day 15, because they were neutropenic. And there is, as I was saying, that there is some amount of immune dysfunction which is there, exists in these patients, and the neuropathy. So infections and neuropathy and neutropenia, which precluded the use of the subsequent week of vinblastine. Whether a single dose of vinblastine instead of CHOP is going to be better, I don't think that is going to be an answer, because if you look at the premise on which that vinblastine is being given weekly is more like you are using anti-angiogenic, more metronomic kind of an approach. So just a single dose may not be very helpful. You do need to think in terms of that weekly, but that weekly, even in relatively younger patients, becomes challenging to deliver beyond day 8.
Thank you, ma'am. Dr. Pavitra has asked a question that for ALK-positive ALCL stage 3 disease, chemorefractory disease in young fit men, what would you choose? Haplo versus allo transplant, and what conditioning would you prefer?
So I'm not a transplanter, so I don't think I can answer that question very correctly. But I'm just saying that if you have a full-blown disease and you're talking of ALK-positive ALCL, and you have had no responses to 2 lines of therapy, I think this is a set where you are going to think in terms of all the ALK inhibitors. Instead of bringing in chemotherapy and thinking in terms of haplotransplant, my suggestion would be to think in terms of ALK inhibitors. And once you get into CR, probably that's a situation where you can take them up for auto rather than allo, because allo will have significant amount of mortality. So I would use ALK inhibitor and then think in terms of auto later.
Thank you, ma'am. Dr. Mohammed Rifai wants to ask that is there any role of oral ASDA maintenance for PTCL?
I'm seriously hoping that 3 years down the line, if I do this talk, there will be clear answers. And as of now, there is no data to say that there is any oral azacitidine which is going to be helpful in terms of maintenance. Maybe an oral TFH, but later on, as of now, data-wise, there is no evidence.
True, Dr. Akansha Chaudhary has a question. She has a 47-year-old lady with pathology diagnosis CD30 negative cutaneous T-cell lymphoma from scapular ulcer lesion and has been completely excised. PET CT shows multiple 1.5 into 1 centimeter lymph node with low FDG uptake. Histopathology biopsy also shows reactive. Discuss with the pathologist. They say it's primary cutaneous CD30 negative T-cell lymphoma. Should we repeat the biopsy or keep the patient under follow-up or treat with CHOP?
So I'm just trying to understand, you've already completely excised it, right?
Yeah,
so if you've completely excised, then there's no question that we can do a repeat biopsy. it looks like primary cutaneous because your nodes are reactive. Yeah. So it's very unlikely that it's a systemic lymphoma. So CHOP is definitely not an answer. And if it's a single site disease which has been completely excised and it's a CD30 negative cutaneous lymphoma, then in that case, my suggestion would be to closely watch. You can think in terms of radiation. That's another alternative. If you feel that the margins, etc., have not been completely clear, if your margins were positive, then in that case you can think in terms of only local RT. But definitely, I don't see any value of adding a systemic therapy as of now.
Manju, can I say something?
Yes, ma'am.
So she's saying it's CD30 negative, huh? And so if CD30 negative T cell, that means there's something large cell and it is T cell. I think I would be a little worried. Maybe get an Eberish done on this and get a CD56 to rule out a cutaneous presentation of an anti-T cell lymphoma, because then that challenge will totally reverse, because then you will not going to you're not going to just observe it. So just get an Eber, because the nature of indolent is CD30 positive. The negative ones are the worrisome ones.
Yeah, my only concern here, madam, to treat on this as of now, sorry, I'm bringing in almost like a lymphoma JC here and trying to counter you, is to, it's a single site lesion. Even if it reappears, we always have a chance to watch re-biopsy when it reappears. And if the pathologists feel that it is aggressive, is something which has to be done very, very carefully, because many times these lesions have, they mimic anything and everything under the earth. And therefore, one should be very careful before we plan any aggressive therapy that we have the correct diagnosis. So if it's a single lesion which is completely excised, go ahead and do the other workup, as Dr. Tanuja is suggesting. But I would carefully watch as of now rather than do anything more.
And that sometimes the PET CT gives a false negative nasal. They miss the nasal mass because of low SUV. So maybe just get a review, because we've had cases like this in the past. So I'm just a little worried. That's it. Thank you. Sorry to.
No problem.
Thank you, ma'am. Dr. Krishna Karan wants to ask that if a patient is ALCL or PTCL, now in CR1, would you proceed with high dose therapy and transplant, auto transplant such patients?
So yeah, between allo and auto, I think next question is allo. When do you consider allo? So I think between allo and auto is a better choice, given that you have low transplant related mortality, and if you account for transplant related mortality, the outcomes are very similar. So I would err towards the autologous stem cell transplant rather than doing an allogenic stem cell transplant. And benefit is largely based on what these studies are there either an ALK negative ALCL, AITL, and then comes the PTCL. So if you have CR, complete response, or for that matter, partial response, these are the patients who can be considered for auto transplant.
Thank you, ma'am. Dr. Babita Shodhi has a question. How much percentage age of T-cell lymphoma or any other subset is positive or are EBV driven, as I understood from your talk, that some T-cell lymphomas are EBV positive?
Yeah, so NK T-cell lymphoma all. So, all NK T-cell lymphoma, which we are talking here in terms of extranodal NK T-cell lymphoma, they will be EBV positive. You may get EBV positivity even in the AITL. So that's another subset where you can have the EBV positivity.
True, ma'am. Again, one question. Okay, that's all.
Okay, so I think the same previous one, whether the repeat biopsy of lymph node is needed or not. If you had a representative node which has been biopsied, then I wouldn't recommend doing a repeat biopsy, because it's more likely the draining node which is showing some reaction rather than being actually disease. So if you're confident, your pathologists seem to be confident that the biopsy is representative, it's not that it's crushed and they can't interpret, then I don't think doing a repeat biopsy is really required. But yes, a close follow-up is very, very important here. So I would suggest that you see them roughly 4 weeks from now. And if you don't see any lesion for 2 subsequent such follow-ups, then you can probably increase your gap more than that. Because if it is an aggressive lymphoma, it will come back in that much time. It's not going to remain under remission.
So if anybody has any other question, because I finished all the questions from the chat box. So any of our discussions, any question? So, well, there are no other questions, ma'am. Thank you so much for that wonderful talk. It was very, very lucid, very easy to understand. and you made all our doubts very, very clear, ma'am. Thank you so much for the wonderful discussion also.
Thank you. Really enjoyed last 1.5 hours. It was very good. Thank you so much.
Thank you, Manju. Thank you. Excellent lecture. Thank you. Bye. Bye, everybody.
I request Zydus to please go for final vote of thanks.
Sure. Thank you, Dr. Manju Singer, for sparing your valuable time on this Sunday afternoon. It was a lucid presentation and different aspects of PTCL were covered in your presentation. And we have many key takeaways from this wonderful presentation. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal, sir, for providing us this opportunity and making us a part of this esteemed academic discussion. I also thank our chief guest, Dr. Tanuja Sheth, program convener, Dr. Amit Purana, all the discussants and participants who have joined us for this webinar. Last but not the least, this series of webinars is possible only because of continuous support from Perfect Square team. Thank you so much, everybody. Have a lovely weekend.
Thank you.
Thank you, Mr. Thank you. Bye-bye.